On behalf of the Board of Directors of Offer, I'd like to welcome you to our presentation tonight. It's my honor to introduce tonight's speaker. I apologize for reading the introduction, but as you will see, her experience and background warrant me being accurate. Jan Favero Chambers is the president and founder of the National Fibromyalgia and Chronic Pain Association. Her national advocacy and policy work is towards improving access for the care of people with fibromyalgia and chronic pain. Jan was appointed by Senator Orrin Hatch to work on the Pain Care Forum in Washington, D.C. There she is the Institute of Medicine in Pain Report Task Force. She's the director of that organization. The Pain Care Forum members include patient advocacy organizations, biomedical companies, and industry. Jan studied health and education at Utah State University and is a certified instructor for the state of Utah's Chronic Disease Self-Management Program. As president of the National Fibromyalgia and Chronic Pain Association, she directs the development of patient and provider materials, exhibiting at national conferences. She develops and oversees programs such as May 12th, which is a National Fibromyalgia Awareness Day. She does those kind of events as well as working in alliance with other organizations to advance fibromyalgia research and education. Traveling over 250,000 miles in the last 3 years to educational conferences and meetings with researchers, support groups, civic leaders, and for advocacy work. Jan has a keen understanding of fibromyalgia and chronic pain concerns for all of the stakeholders. Her involvement in local and state politics for over 25 years has benefited her advocacy work, as you'll hear tonight. She graduated from Yale Law School's Women's Campaign School. Jan lives in Logan with her husband Joe. They were high school sweethearts and then together raised 5 children. She was diagnosed with fibromyalgia in November of 2006 and was bedridden with FM for about 16 months after having had an abdominal surgery that previous December. Now, probably after all that information, you can see why it is such a pleasure for Offer to present Jan Chambers.
It is a distinct pleasure to be here with you tonight. Can you hear me well enough? Okay, good. But Dennis, is that better? When we do presentations for videotapes, I've learned that you have to have the microphone right here so you don't project a certain sound over it, so this is a better position. Well, thank you for coming out on this winter night that we think spring is soon coming. It's nice to be here with you. Understanding the trends in fibromyalgia and chronic pain is really empowering, and that's what these meetings are all about. And I do appreciate Linda Milne and the Offer Board providing these opportunities for the community. It's very, very important. They've been doing it for, I looked it up, and it was 11 years. And so this is a wonderful event that we're able to gather together and be here tonight and to understand the changing events that are happening in America. And I want you to know, as I visited with Linda, I expressed to her, I understand a lot about the changing politics in America and what's happening with the Affordable Care Act and with the Institute of Medicine Pain Research Report. And I don't like to come and alarm people. I like to come and bring solutions and recommendations along with those concerns. And so tonight I'm going to try to help you understand some of the changes that are happening. But I do have to put a little caveat in there that we don't know how the end is going to turn out yet. We're still very much in the fray of the work itself. please know that I expect you to make yourselves comfortable. If you need to get up and move around, if you need to wiggle, whatever you need to do to be comfortable, please know that I will be very comfortable with you doing that. At the National Fibromyalgia and Chronic Pain Association, we are organized across the United States. Sharon Waldrop lives in Michigan, and she is our Vice President for Education. Tom Hintz lives in Wisconsin, and he's our Vice President for Support. Our Leaders Against Pain Director lives in Arkansas. And so as we work together in our weekly meetings, and sometimes more often, to coordinate our efforts, there's a lot going on across the nation that we keep an eye on and that we're working together. I want to introduce to you a little bit about my organization. This is our newsletter, the Fibromyalgia and Chronic Pain Update. It's called The Advocate for a reason, and that is because it's mostly about what's going on in the changes across our country. The newsletter, it goes out to about 80,000 subscribers every month. Then we have our magazine, and it's called Fibromyalgia and Chronic Pain Life. And we refer to views since it's digital. You can receive it in print, but since it's digital, we refer to views, and we have about 40,000 people per issue who view this. And then we have our National Fibromyalgia and Chronic Pain Association's Facebook. We started this in July of 2011, and we're very fortunate because our fans are very active. We ask questions, we learn from them, they give us responses. Today's question was about yoga and how people are involved in either the mindfulness or just the traditional poses, and wanting to know more information about that so that we can take that to the researchers and help them understand what people are using in their everyday lives to help themselves. Then the NFMCPA has their Blog Talk Radio. We air this monthly and have a guest and speak about current issues or call people to action. And then we have our YouTube channel where we have the Ask the Expert program. And Dr. Lucinda Bateman is going to be our guest on April 27th, I believe it is. On April 24th, discussing juvenile fibromyalgia. And we have our website. And as you can see, we're deeply involved with the fibromyalgia, the chronic pain, and the overlapping conditions community. All of this leadership our mission is to bring together advocacy, research, and education to transform lives. And we're all people with fibromyalgia, and the people that we feature in our magazine are people with fibromyalgia and chronic pain. And we understand what's going on at the corner where people are trying to fill their prescriptions at the pharmacy, and we understand what's happening on a national level sitting around the desks in Washington, D.C. It's important to know that fibromyalgia affects everyone in the family. My family, which includes my husband and 5 children and their spouses, have a standing joke that I never stop talking about fibromyalgia and always intertwine it into our conversations. From my travels and interactions with patients and broad stakeholders, I see how chronic illness affects every aspect of life: the social, financial, spiritual, health, lifestyle choices, and the personal aspirations. My family's humor reminds me of that movie that we all enjoyed a few years ago called My Big Fat Greek Wedding, and where the main character's Greek father always related everything to how it had its origins in Greek. The funniest is that word kimono, and the young girl in the back seat asks him, how is kimono Greek? And he says, well, it was derived from the Greek word himonos, for winter. And what do you wear in the winter time to stay warm? A robe. So you see, robe, kimono, there you go. So as we live every day with fibromyalgia, it does intertwine in our lives, and it does have a connection. And we need to understand that connection and how we can become educated and empowered to understand how we relate to our communities, how we reach out and take advantage of what's around us to use. Well, we laugh about my passion, but as my family goes forward and shares their experiences with me, I know that they are good fibromyalgia advocates in the appropriate situations. My second son recently was interviewed across the nation for MD and MD PhD programs, and one of the interviewers asked him an interesting question. He had put on his resume that he had volunteered for the Utah Fibromyalgia Association for 4 years. And she said, why would you want to work with such an unappreciative and unrewarding patient population? And with his personal experience as a son of a mother with fibromyalgia, he explained how fibromyalgia first horrified and then galvanized our family to learn how to support one of its members. So what is the cost of chronic pain to society? In the Institute of Medicine's Relief in America, the IOM report that we refer to so lovingly, they showed through a lot of research that chronic pain costs America $560 to $635 billion annually. That's unproductive resource at the office. That's the direct medical costs. That's the cost to each family. All of that was combined. But what's important about this, it affects 116 million Americans. That's almost 1/3 of America. It's between 1/4 and 1/3. It's like epidemic. And it's also important to understand that it does not include children, military personnel, people in prison, or people in long-term facilities. So my son's experience with his, the interviewer's comment as it being an unrewarding and difficult population is a common comment. It's both a verdict and a call to action. And of course, this is an unflattering ranking in any demographic, but it's especially important for us to recognize it and say, what shall we do about this as a community? Because it's very apparent that we need to change how we're interacting with those around us. First, our families and our neighbors and loved ones. Second, our communities, what access we have to the healthcare providers. And third, how we provide those relationships to be sustainable and find ways to be a part of society, that we're not a drain on society. And I feel pretty comfortable because we are all in this pot together. And so I know the things that I'm speaking about. I'm going to speak pretty directly tonight because I think it's a time for us to speak directly. And as Linda and I were talking at dinner, and I said, you know, it's very concerning when I see what's happening with our Medicare, our Medicaid, our health insurance, and the Affordable Care Act. It's very concerning for this population, and I'll tell you why in just a minute. Well, we've come a long way in 37 years. In 1975, Harvey Moldavsky found that patients with fibromyalgia demonstrate abnormal brain activity during sleep. And in 1984, Dr. Muhammad Yunus described overlapping clinical situations of fibromyalgia, irritable bowel syndrome, tension-type headache, and primary dysmenorrhea syndromes. And he clearly depicted their correlation by Venn diagrams, so he showed how they overlapped. And we've come a long way since then because we know now that it overlaps with approximately 70 other conditions. So what has changed in all of these years, in 37 years, when you realize that before that, fibromyalgia has always existed, but in 37 years, we now recognize that fibromyalgia is a central nervous system sensitization. It's a central nervous system sensitization. You'll hear that term in a few different ways. You'll hear it as a central sensitivity syndrome, as a chronic pain illness that has to do with the central nervous system, but it all relates there. So here we have this large gulf between the research and what's happening in our doctor's offices. Well, that gulf is called translational research. That's what we need to have coming from the National Institutes of Health. That's what we need to have coming from our researchers, is they need to take that and say, okay, this translates into A, B, C, D in the clinical setting. It's been very useful to have it set out just as research, but now we need to move towards translational. Well, I think that with a lot of hard work, we can really embrace and turn what's happening around for our community. From my vantage point, 3 things need to change. Healthcare providers need help managing the burden and the cost of caring for people with chronic pain and fibromyalgia. Secondly, we need to educate people with fibromyalgia. Third, we need to lobby for significant research funding at the NIH. And I want to pause for just a minute about educate people with fibromyalgia. I didn't say about fibromyalgia, I said with fibromyalgia. And that's a very important point here, because when we talk about understanding our community and interacting with it, we have to have literacy. We have to understand the terms. There was a report issued, it's been about 10 days ago now, from the Institute of Medicine that I read right after it came out, and it was all about about the literacy and where it's at in America. And as I read it and used my highlighter and pen going through it, I kept thinking, wow, this is a big gulf here, because the people with fibromyalgia, the symptom of cognitive dysfunction, where they don't remember things, they can't call on that word, or they have a brain freeze, they can't understand a lot of this information. So part of my advocacy is to discuss health literacy. I'm mentioning it to you tonight because as you go forward and talk to other people, especially your healthcare providers, ask those questions. Make sure that you write down what the information is. Don't ever feel like your question's not important, because when you walk out of that office, you're the one who's responsible for implementing whatever's been discussed there. So first of all, I said that we need to recognize that primary care physicians and nurse practitioners need help in managing the increased burdens of our community. We are focusing as a national organization and with the people that I work with in Washington, D.C., on those two areas specifically, on nurse practitioners and primary care docs, because they're the ones who first see their patients. They're the ones where the intakes are taken. That's where all of the history and the basic tests are performed. And they need help, especially with the rising awareness that we have of fibromyalgia and chronic pain. We bemoan a lot of times what the pharmaceutical companies do on this or that, but they have done one thing, and that is to bring more awareness of fibromyalgia across America. So I am appreciative of that. But as they bring more awareness and people recognize and identify with that, then they end up in their primary care's office and they are overwhelmed. When I was at the ACR, one of the discussions was about how much the costs of treating fibromyalgia were overburdening the offices, and they were trying to scoot the patients out the door. And we'll talk about those in the home medical teams in just a minute. So in Spain, which was the best, originally I only looked at American research. And then I realized that was a little myopic because we don't have a corner on fibromyalgia. And it's interesting, in different countries there are different levels of fibromyalgia. And I can't remember which country it is, but one of them claims to virtually have none. So I don't know what their research is, but that's hard for me to believe. And then even, in some of the cultures, like the Amish culture, we would expect fibromyalgia to be pretty much straight across the board, but it's actually, there are different pockets of fibromyalgia. Well, what they showed in Spain is that the annual cost of treating fibromyalgia is $10,391. So this is expensive. So the insurance companies have come to a decision, are coming to decisions, to deny fibromyalgia coverage. I had an opportunity just about 2 weeks ago after somebody called me and said, I was denied coverage on fibromyalgia, will you check it out? So I called the state health insurance department, spoke with them for quite a while and said, what's happening? Is this really true? And he confirmed every one of my questions, and he said, if you have any opportunity to make people aware of what's happening in our state, please do it, because we're really concerned. Our group is right in the middle. A lot of the population of fibromyalgia is middle class, and then if people haven't been able to work, then they've been able to access the Medicaid and the Medicare programs if they are disabled. And as we go forward with the Affordable Care Act, this population is changing, because the Affordable Care Act mandates that 143% of the poverty level, people who meet that guideline, now fall under Medicaid and Medicare, but specifically Medicaid. I had an opportunity to speak to our state legislators last week, and I asked them, what is your concern with what's going on with the way that the federal government is pushing all of this additional patient population onto the state? What are we going to do? And he said, Jan, we only have one pot. And remember, we're a balanced budget state. So we have to take it away from another group, or we have to slim down what the people are expecting to receive in Medicaid. So that's why I'm saying we need to start having some pretty serious discussions about what we're going to do as a population, how we're going to approach our legislators, how we're going to speak up for ourselves, and how we're going to have the forward, the progressive actions that we need to help ourselves, to advance the research, and to make sure at the same time that we're not leaving anybody behind. So I want to make sure that we cover this point. I asked the State of Utah Insurance Department, what happens to somebody if they don't have insurance? And he said, well, that's the group that we're most concerned about, because with the insurance companies saying, no, we won't cover fibromyalgia, and that person doesn't qualify for the Medicaid, or if the premiums right now are allowed to be between 18 and 30% of an increase every 6 to 12 months, then the premium for people, if they are covered for the chronic pain and fibromyalgia, is a very high premium. And when it comes January 1st of 2014, yes, everybody will be covered or be required to buy insurance, but nobody's been talking about what the cost of those premiums is going to be. And so you have a large population that is not going to be able to afford those very high-priced premiums as we're seeing now, even though it will be changed and they'll be covered. So we really are losing ground. And it's important to understand that the state of Utah was one of 4 states who began the lawsuit against the federal government to have the Affordable Care Act separated out. It's called separability. And the part that Utah is advocating for in the legal courts is that people, they've crossed a line by forcing the constituents or the citizens to buy health insurance. You're actually crossing over into commerce. And never before in America has the federal government mandated that American citizens buy a product, which is exactly what they're forcing, that we buy a product. So this is the discussion in the Supreme Court at the end of March. Now, we aren't expecting a decision. We don't know if they'll take it under advisement until after the election, or if they'll come out quickly with it. But everything that I'm seeing is that we're rolling forward, and we're rolling forward fast with the Affordable Care Act. So I really appreciate this opportunity to be here tonight and to make a cry out and say, please pay attention, because this affects the people that we know and associate with who have fibromyalgia also. I was speaking to a young resident in Idaho recently, has another year in her residency program, and I asked her, so, what are you seeing in your primary care practice? And she said, I don't know what to do for people with chronic pain. They just don't they aren't engaging. They're not taking responsibility from, a physician's point of view. They come in because they have somebody who will listen to them. They're pouring a lot of their information out on me. We only have a short period of time, and I don't know what resources to give them. And I try to pick out just one thing that I think is doable and changeable and discuss that with them. But then I meet resistance. I said, so is this common? Is this pretty much across the board? And she said, yes. A few people are willing to really try to engage in a partnership, but for the most part, no, they want me to solve all their problems. So I told you I was going to speak pretty frankly tonight. So we need to shape up our act. We need to clean up our act as a community. We need to help our physicians help us. And then when you take this into perspective of the additional increase of people who are recognizing and identifying with fibromyalgia and chronic pain and are asking for help, then you understand that these physicians are overwhelmed. Another thing I want to just briefly touch on is the DEA, the Drug Enforcement Administration, the private insurance, step therapy, and specialty tiers. Right now, we've been following this very closely in Florida. The DEA has been very concerned about the opioid use. So they have clamped down a lot. What they did decide to do was, instead of going after individuals who were using a lot of opioids or the physicians who were prescribing high percentages, actually it's the top 30% tier of those prescriptions, they decided to go after the pharmacies who had the highest prescription, that were filling the prescriptions, and the wholesalers to those pharmacies. And they happen to be CVS pharmacies in Florida, and I can't remember the name of the wholesaler. But they prepared a counterclaim to it and said, it's not really us, we're following the law, and you cannot make it so that other people can't get their prescriptions. So on our Facebook, I put out a couple of queries, and I asked, is anybody having problems across the United States with getting your prescriptions filled? And Washington State is a completely separate issue than Florida, so let's focus on Florida. But people said, yes, what's happening is that we go from pharmacy to pharmacy because the supply's been cut off. The pharmacists are saying, if you have cash, we will sell you this medication. We'll fill your prescription. They don't want to bother with the insurance. I was shocked, and the people were pretty outraged on our Facebook page. The other thing that's happening with the medications is our older generic medications are when they started doing that $4 prescription deal and made it really cheap to get, like, for 3 months and stuff. Well, a couple of things happened up the food chain. Number one, the profit ratio changed, of course, and immediately some of the companies lost interest in it. But secondly, the most important part is that the compounds, the ingredients for those medications, weren't pure. Nobody really seems to understand how that's changed, but the standards for those medications have not been met, and so they've been pulled off the shelves. And a lot of our standard medications, like, and then you have the other part of it too, where the FDA is saying, these medications have been around for a lot of years, but they never went through any stringent guidelines or testing, and so they're pulling off the quinolones, they're pulling off the older generic medications that were never tested. So people who have been using off-label medications to, have even just some management of their chronic pains and their symptoms, we stand to lose a lot of that. And I don't have the list with me here tonight. There's a meeting that I attend that discusses that specifically, and it's hard to eat breakfast there when we're talking about it, because I get so concerned about the people that I know need these medications, and they do too. So tonight I'm talking clearly about the politics, the science, and the psychology of fibromyalgia. We're not going to get into the psychology as in going and seeing somebody who will use psychotherapy, but there is a psychology around fibromyalgia and how we need to address it, we need to embrace it, and understand what we're going to do with it. So right now, it's interesting how things happen, but I've been invited to send a letter to Health and Human Services Secretary Sebelius and give her my feelings on the IOM report. I've been thinking awfully hard and late at night about what I want to say to Secretary Sebelius about this, because it's a very, very concerning situation. And here's one of the reasons that I'm willing to invest my time. By the way, I'm a volunteer. Nobody pays me to do my work. Everything that I do is supported by my family or the funding that I'm able to arrive at. But anyway, by the end of 2012, there are some things that are going to happen with the Affordable Care Act. The first one is that Secretary Sebelius, by January 13, 2013, is required by this new law to certify every state in the nation to have an insurance exchange. Well, when they first talked about insurance exchanges, it sounded like, oh great, we're going to have this place where we can go and all find affordable health care insurance. But that's not the case at all. There were a few meetings in, this is March, in November, and I was invited to attend them. And they were held by Health and Human Services, and they were establishing what are called EHBs. They stand for Essential Health Benefits. And they were creating a list that we thought they were going to say to the states, you have to have at least these minimum benefits for the people in your state when you create these insurance exchanges. When we got the list, they were so weak. There were 10 areas, and chronic pain was not even on the list. So the group that I work with in Washington, D.C., the Pain Care Forum, I drafted the letter for our members, and I think we had about 75% of the people sign on. Pretty significant. But what I want to say about Health and Human Services is they're taking a very minor approach, and they don't want to ruffle any of the states right now. So these states are having like a maverick heyday in developing the guidelines with the legislators and what they're going to have as their guidelines in their states. And the state exchanges are nothing more than having a place where all the insurance companies come together and then respond to what the legislators in each state have said will be the minimum standards or the essential health benefits in each state. So what you have in Kentucky, what you have in Georgia, and you have in New York, and California, and Utah are very, very different. In the literature that I read, Utah and Massachusetts are held at both ends of the paradigms. Utah is considered to be a very, very weak state health exchange, and the way that it was set up was so that small employers could come and find insurance for their employees. But often it was more expensive to go inside of the exchange. I remember going and looking for our small company. And in Massachusetts, it's basically socialized medicine. Everybody is required to pay into the medical system, and everybody has insurance. So you have these two very polar opposites, and then the states are creating their exchanges in between with the legislators deciding what is going to be covered. Well, I'm mentioning over here the insurance policies. We've discussed that pretty well, but the doctors diagnosing fibromyalgia, what's happening, I just want to talk about Utah right now. So in Utah, if you have fibromyalgia as a diagnosis on your record and apply to some insurance companies and they deny you coverage, the doctors have a knee-jerk reaction to it to protect their patients. They don't diagnose fibromyalgia. They'll write anything else in your chart, and I even know where some patients are asking their doctors to go back and basically expunge their records so that they can get coverage. Well, this isn't going to help because now you have people who don't really understand which direction to look for help with their diagnosis. They don't know which illness it is because, as we all know, we have a lot of symptoms. And when we don't know to be at ease with a lot of those and to not worry about them and just recognize them as, this is kind of maybe like the weather was bad or the stress was extremely bad, and so it caused maybe the irritable bowel syndrome to be higher or the heart rate to be changed or something, one of the symptoms. So it really is important. It's empowering for people to know their illness and to have a name. And we're having a problem in Utah right now with that, with the doctors not diagnosing because of the concern of the non-coverage. So you take that a step forward, and if there is severability in the Affordable Care Act and the Supreme Court decides that people are not required to buy insurance, where does that leave our community? It's still in a really difficult place because now nobody's required to cover us. The premiums are high, extremely high, and a lot of us, most of us, don't qualify for Medicare or Medicaid. We don't, we haven't been given the status of disabled. So, yes, ma'am.
I'd like to know the definition of this word, fibromyalgia, Okay, we know malaise. We know what that means, most of us. And then we know fiber. Put them together. What are we talking about? Giving it this name, please.
Thank you for your question. She's asking how did we come together, if I can restate it, if I'm incorrect, please correct me. She's asking how did we get to this name, fibromyalgia. It started back I have another lecture prepared where I discuss the history of fibromyalgia. And it was called fibrositis for many, many years, and actually it was originally called women's hysteria. And so it's been recognized in the literature. I think his name was Gowan back in about 1801. And so when you go back that far in the literature, you see it. But what happened was that it was being felt, the pain was being felt in the muscles. And so that's where you have the fibrous part of it. And the myalgia is the pain. And so it was originally perceived that the pain was in the body, and that's why we're actually in the College of Rheumatology, because rheumatology is about the joints and the muscles. And, you know, fibromyalgia symptoms are very similar to rheumatoid arthritis. And there are tests that can define that, know if it is rheumatoid arthritis. So there was a lot of work about 3 years ago to move fibromyalgia from the College of Rheumatology into, it's called NINDS, and it was at the National Institutes of Health, so that it could be considered a neurological illness. Well, there's been a lot of shifting in the research area, and that's why I said at the very beginning, now fibromyalgia is recognized as a central nervous system illness, because what's going on in our brains is playing out in our bodies. And so the brain is hyper-aroused, and over time becomes more aroused and more sensitive. And when you have information from your environment, such as sitting on a chair, or a breeze, or loud noises, or bright flashing lights, your brain is so involved in just maintaining your life that it doesn't respond to that sensory information correctly, and it thinks that it's pain. The theory behind this is called the dopamine theory by Dr. Patrick Wood, and he postulates that the hypothalamus doesn't make enough dopamine, and so that's a neurochemical that downregulates pain. And just a final quick wind-up on your question, fibromyalgia patients have a significantly increased amount of substance P. And substance P is a neurotransmitter to help information be transferred faster. So you put this all together, and that's how we got here. Whether or not we should be here, I don't know, but we don't have a lot of choice or play in politics on that. And the ACR has actually been very good to work with and to keep us in their fold. All right, now we get into the part that I really love. The politics surrounding fibromyalgia are the decade of pain control research, 2000 to 2001. Linda, I apologize. I usually put my phone here so that I know where I'm at on time. And like I said, this is my passion, and I can talk for a long time. So I kind of need an indicator of, number one, the time of how long you want me to go, and number two, of the interest. Because if people are getting uncomfortable and it's time to go, I'll stop, because I have a tendency to use a fire hose. So the decade of pain control was, actually I'm just going to go through these very quickly. The politics are here, and then we'll go through each one in just a minute. The IOM Relieving Pain in America report, the U.S. Senate Help hearing on February 14th, just a few weeks ago, this new NIH Interagency Pain Research Committee, and increasing patient voices at the table. The science is the research trends that fibromyalgia is a chronic pain illness, not looked at in its own silo anymore, that the fibromyalgia diagnostic criteria is still in a state of flux, Then we have to look at the NICAMS, which is the National Institute of Complementary and Alternative Medicine, and what they're doing to shore up the things that we know help us, and that lifestyle choices affect fibromyalgia. The psychology is that we need to change the cultural attitudes towards chronic pain, both inside and outside of our community. Then there are the psychosomatic considerations of fibromyalgia and how we respond to those. Then lastly, there's the home medical model that is coming about very quickly, and I'm sure a lot of you have already interacted with that, and our patient responsibility towards that partnership. So the decade of pain control and research. In 2001, Congress passed into law a provision that President Bush signed, and it said that the decade of 2001 to 2011, we would have pain control and have the research and the treatments. Well, a funny thing happened on the way to the forum. The Democrats had control of both houses, or both, full Congress. And so I just want to show you right now, and I'm not here pushing it either way, I'm just telling you the facts as they are. So we had, and as a citizen, it's really been alarming to me to understand how our government works. And being there in DC and trying to get, one arm says, we want this to happen, and the other arm just like, it never happened. It's just amazing. And so who is the person what's in between this? It's us. It's the organizations, it's the people who are affected by these illnesses, and that's what we need to understand. So anyway, in 2003, House bill by Representative Mike Rogers of Michigan brought it to the House. It went down. Brought it in 2005, it went down. So in 2007, Lois Capps from California, a lovely lady, decided that she would join on to this. And make sure you're comfortable if you need to get up and move. And then it went down. 2008, it went down. Well, 2009, Mike Rogers went off of it, and only Lois Capps carried it forward, and it was passed. It went sailing through. Well, it was interesting because on the Senate side, in 2008, Senator Hatch and Christopher Dodd, they decided to do it. I'm kind of getting away from the term bipartisan. There were two groups that came together, and it went down. Then in 2009, an interesting thing happened. 3 parts of the National Pain Care Policy Act were considered more fully and adopted into the Affordable Care Act. So in 2009, it went forward to the Health Committee, to the Health, Education, Labor, and Pension Committee. That was the farthest it had ever gone. And it took, how many years? 8 years for that to happen. So in the background, you have all of these patient communities that are working together to try to get their senators and their representatives to be responsive to this. I have written hundreds of letters. I have delivered hundreds of letters. And in fact, at the patient conference, I took letters from the patients, the people who were attending that conference and who signed I can't remember. I took them to Senator Hatch anyway. So it's important to understand how the Affordable Care Act adopted this movement of the pain control and research. As I said, the catalyst for change is common citizens working together. And the Pain Care Forum has been behind most of this. A very, very brief history. The idea for a National Pain Care Policy Act came out of the Pain Care Forum. They actually drafted the original National Pain Care Policy Act, took it forward to Mike Rogers, and asked him to carry it forward in the House. And then it's gone from there. The Pain Care Forum is a group of patient advocates, businesses, professional organizations, and then the biomedical. So I mentioned that there were 3 provisions from the National Pain Care Policy Act that became amendments to the Affordable Care Act. We're pretty sure that those amendments will not be taken out if the ACA is severed. So have you ever wondered who advises the federal health for the government? It's the Institute of Medicine. The Institute of Medicine is a part of the National Academy of Sciences. I had the pleasure of going there a few times in the past year and a half and meeting with their senior directors and such. And if you ever get to Washington, D.C., don't miss the National Academy of Sciences. It's just as wonderful as any of the museums that you go to. So the Institute of Medicine was charged by Congress to prepare a report. Congress, let me just make sure I give it to you exactly as I researched it. Just to back up for a minute, the National Academy of Sciences was chartered by Congress to perform this function for our nation. So it wasn't a private group that just came forward and said, hey, we'd like to do this. It was actually chartered. So the Institute of Medicine was so I've lost my place in my notes. So the Affordable Care Act came out and it said that Health and Human Services had to create a report to come back to Congress and tell them what is the state of pain, chronic pain in America. Well, I as a citizen thought, oh great, the ball's rolling. Congress, the Health Committee specifically, has told Health and Human Services Secretary Sebelius that she needs to get a report from the Institute of Medicine. Once we get that report, we're in good shape. Well, no. We had to lobby for weeks and weeks and weeks to get a Health Committee hearing on their own report that they asked for. And I love our system, but I'm telling you, it's neurotic. To try to interact with it, it's just crazy. You have to really pay attention to what's going on, who's supporting this and who's supporting that, and whether or not they're friends at lunch, and oh my goodness. But anyway. So I want to get to what the chronic pain report said. And I've already told you that there were 116 million American adults, $560 billion annually. But most importantly, they said that the pain treatments are inadequate. And they said that we need to have a cultural transformation in the way that pain is understood, assessed, and treated. I didn't bring it with me, but I have a copy of they're called Unproofed, the book of the pain report. And in it, if you held it in your hand, you would know that it's one of the most powerful tools that we've ever had as a pain community. This group of 19 people who were hand-chosen by the Institute of Medicine to form a committee and to look at chronic pain in America really heard us. They really looked into it. They listened to all the biases that I've been talking about tonight. They listened to how much it's costing Americans. They really came out of this thing with a great report. Now, the figures were astounding. Nobody was expecting them to be this high. In the back of each section are between 135 and 175 research papers that back up all of their data. Well, I was... this Health Committee that I'm mentioning, that we lobbied hard for, I was very privileged. I went to Washington, D.C. I arrived at the meeting room an hour before. It's a beautiful room, as elegant and as wonderful as you'd ever hope that our country has. And I prepared written testimony for fibromyalgia. I wasn't chosen as a witness to give verbal testimony, but I fully supported Kristen Beasley, who's from the Vulvodynia Association, and what she reported, and I'll share just a little bit of that with you in a minute. But what I want to say is that I asked Dr. Daniel Claw, who's one of the leading researchers for fibromyalgia in the nation, to also prepare a written testimony to Congress. And they'll be sharing that in our next issue of our magazine. And he said there were three things, and this is the first time I'm being public with this, but he said three things to Congress. He said deployment to war, motor vehicle accidents, and illnesses, very serious bacterial or viral illnesses that have affected the central nervous system, are the precursors for fibromyalgia. It blew me away because, I've been following the research for a long time, and I know the different pockets. And I thought, oh my gosh, this falls. I don't think he had read the Institute of Medicine report, but this falls right in line with what they were reporting. So I'm going to step away from that for just a minute, away from the Health Committee hearing, and talk about the 4 recommendations that are going to happen with the Affordable Care Act before the end of 2012. So the first one's already, the designated lead at the National Institute of Health has happened, and the support collaboration, we've got a long way to go on that. We're trying to bring people to the table to talk about, giving up some of their territory and just talking about how we can help people with chronic pain. But we still need to develop a strategy for reducing barriers to pain care, and Secretary Sebelius is charged with developing a comprehensive strategy for pain prevention, treatment, strategy, management, and research. Now, the report came out in June of 2011. What is that? 16 months that we have to literally provide for our whole future. That's why I said things are rolling out really fast. And this discussion tonight is to underscore the importance of everyday citizens actively advocating to your legislators and your policymakers about your concerns, because they figure if they hear from one person, they're not hearing from 100. And so your voice matters when you have an opportunity to speak out. So I mentioned this new National Institute of Health Interagency Pain Research Council. First time ever that we've had patient voices at the table. This committee, I believe it has 21 members. It has researchers, it has academia, and it has patients. And I know Tamara Lillard, wonderful lady from the National Fibromyalgia Partnership back in Maryland, and she's doing a wonderful job. These terms will be about 2 years and they overlap. Terry Cowley and I work with her very closely, the president of the TMJ Association, and Kristen Beasley, lovely lady. So anyway, I'm excited because this is the first time ever that we have had an opportunity to be at the table. I'm going to jump ahead because of time and talk about the research trends. Fibromyalgia is a chronic pain illness. I spoke about that a few minutes ago. And Dr. Alan Light is doing some very important research here at the University of Utah on biomarkers in the blood. And I'm not versed enough to speak about his research, but I do know that it has a very strong correlation to exercise. And so, when we talk about exercise for fibromyalgia, one of the take-homes tonight, the takeaways, is to be looking at yoga, to be looking at the stretching exercises, not the exercises that are producing a lot of lactic acid in your muscles. We need to discuss the stress management and the psychological aspect of fibromyalgia. The chronic pain research report was adamant that the allostatic load, the pressures, the way we learn to manage stress throughout our life from when we're born until we're adults, has everything to do with developing chronic pain as an adult. The way that we manage stress. We've been hearing this for years and years and years. And it's finally time for us to give ourselves permission to relax and to really take to heart some of those stress management events. If it's working with some of the elements of hypnosis, a very deep relaxed state, look into it if that works for you. Starting to be a self-manager is very, very crucial in this climate. That's one of my second take-home messages tonight, is that our community needs to learn self-management techniques. Until we have that translational research, which is probably 8 to 10 years away, we need to be taking care of where we are now. We are in charge of ourselves. We can trust ourselves. We know which of the CAMs, the complementary and alternative medicines, work best for us. And when I was at the ACR in November there were 3 or 4 of they're called over-the-podium presentations. They're the ones that didn't make it to the general keynotes and such. And they kept stressing that there were 4 elements for fibromyalgia to be addressed by the providers and by the people with fibromyalgia. And that is that we need medications at times to help us to manage the pain. And using as minimum as possible is the best long-term effect. Then you have your nutrition. And I'm not talking about losing weight, I'm talking about being wholly developed so that your mind is receiving enough of the omega-3s. I'm talking about taking care of the IBS if you're allergic or have a sensitivity or an intolerance to wheat or eggs or milk. Just cut them out of your diet. There are a lot of other choices. Then we have the exercise, more of the stretching exercises, the yoga, the gentle exercises, and rarely do you want to do any exercises that have an extension of the hip, because about 70% of fibromyalgia has issues in the neck, and all that does is compress the cord and cause more problems there. And then the 4th one is the psychological component. Our community has been particularly adept at pushing away psychology. And I think personally that the psychologists can help us, but we need to help them help us, because a lot of the current therapies are about blame or trying to find a lot of issues, and it doesn't need to be that way. And so I encourage you to think about all 4 of those areas as self-managers. Very briefly, if I would have talked to you here a year ago, I would have spoken about different things in fibromyalgia research trends. Now it's being looked at as a chronic pain illness. Before it was discussed and researched in a silo fashion, meaning that how does this occur all by itself? It was just research for the primary fibromyalgia. But now we know that there's secondary fibromyalgia. Secondary fibromyalgia often occurs, say, if somebody has a knee replaced and the pain just doesn't go away. And so eventually there's the central nervous system sensitization or wind-up. And as the body heals, the knee heals, there's still that continuing pain, and then the fibromyalgia sets in. So that's considered secondary fibromyalgia. It coexists with another condition. You have cancer, pain, and end-of-life situations. Anyway, secondary fibromyalgia. I want to get to a chart real quick. Briefly know that the diagnostic criteria in fibromyalgia is still in flux because the tender points and the self-diagnosis by patients is under attack. Now, I hope that you can read this. This one is one of the most important things I have to say tonight about the National Institute of Health, and that is cancer, heart disease, and diabetes affects the same number of people as all the chronic pain illnesses combined, and yet they spent $360 per person at the National Institutes of Health on research. You can see the figures that they've spent on the other illnesses. The next chart I want to show you, maybe I can make this bigger on my computer. No, I'm not going to fuss with it. What I want to tell you is that when you come down to endometriosis, interstitial cystitis, fibromyalgia, chronic pain syndrome, vulvodynia, and TMJ disorders, personally I think that the fibromyalgia is underreported. It's actually closer to 10 million, but I sure appreciate this chart because it shows how much money has been spent in research towards each one of the fibromyalgia patients, which is $1.50 per person. And you can, when you compare that to the Parkinson's as $172 per person, they're making great advances. We need that kind of research. We have the numbers. We need to be doing it.
I just thought you answered my question. I was wondering what year that was from, but it says 2010.
Yeah, it's recent, isn't it? So I spoke a little bit about the holistic project, the 4 areas to pay attention to. That's called a holistic approach, paying attention to all the parts of a person, not just their physical part, not just their mental part, not just their heart and their spiritual, not just, but to put it all together. And so the research at NICAMS, the funding there is $128 million last year. It was increased $1 million for 2013. And in their budget justification to Congress, they said that 40% of American adults use complementary alternative medication or complementary and alternative medicines, and 12% of American children, that Americans pay 11% out of their pockets to access these CAMs. And the cost of CAMs is 1.5% of the total national care. Well, this is really upside down, because if 40% of Americans, adults, are using CAMs, and we're only allotting $1, for the research on this, we're like pennies to dollars, and we need to be focusing attention on this. The total budget for CAMs for next year is 1/4 of the amount of money that they're spending on depression as an illness research at NIH. It's interesting because the Department of Defense and the Department of Veteran Affairs are wholly engaging CAMs. They recognize that people gravitate towards them and that they're receiving benefit from them. So we have a lot of good data that we're going to be looking towards coming out of that. Now, I mentioned that the IOM report had what's called an allostatic load from birth, childhood, adolescence, and adulthood. And I just want to briefly, if you have grandkids, I just had my first one in last May, and I'll tell you, I'm all over her. Are you doing this? Are you doing that? Are you? No. And because I understand now how it happens from, it's called their environment. So not only what was their environment when they were in utero of the mother's feelings, but also what kind of a cultural setting are they moving into as they are growing up as little children. And the factors that they said were physical, sexual abuse, and other traumatic events such as the death of a parent or witness to violence, low socioeconomic status, hyperactivity, separation from the mother, and an acute or recurring pain experience for children. In adolescence, they discussed obesity, the low levels of fitness, injuries, the education level, and the learning behavioral reactions to pain. So how they see pain handled in their own homes or in their communities or such. The children are learning these things. And then that development of their mind and their understanding of how to manage themselves as adults are set in these manners. This is all straight from the IOM report with pretty impressive research to back it up. Then in adult, you go back to the childhood traumas. This is what these are the factors in adulthood. So vivid recall of childhood trauma, the lack of social support, surgery, overuse of joints and muscles, occupational exposures, job dissatisfaction or low work status, and the development of chronic disease. So we've had a lot of information tonight, and I hope that I'm raising your awareness and helping you understand that you can engage with this kind of information and support the NFMCPA. Come forward and respond to your congressman. Let them know how you feel. Step out, because it matters. So the psychology of fibromyalgia from an organization's point of view is that we need to avert a patient population avoidance. We foresee that with the burgeoning population in chronic pain, especially with the increase in diabetes, that this whole group is going to be avoided. And what is happening is that in the home medical models, they're creating teams, and there's one physician, the primary care physician, who's in charge of that team, and then you have different components. I was talking to Penny Jensen here at the VA hospital. She's the president of the Nurse Practitioners Association of America, and she was telling me that we need to really be paying attention to these home medical models and make sure that our patient community knows how to work within them so that they get the attention that they need. Now, how did that fall on my ears? Avert a patient population avoidance. Because we don't want our population to be so unfriendly and unwilling to engage in self-management and participating with our providers that we get shuffled around. And there's a real potential of that with these emerging models. Okay? So we need to educate, and I've mentioned these. I did forget, sleep hygiene. One of the most fundamental parts of fibromyalgia. Don't play hooky with this. Really pay attention to this. The little things, this is not on my slides, but I feel impressed to share this with you. Dr. Michael Alton at Weber State University has spent his lifetime, I met with him about 6 weeks ago, and he has spent his lifetime creating a stress management lab. You go in and it is so fun. He has biofeedback, he has tilt tables, where instead of standing on your head, you get to just hang the top part of your body. There are chairs that, of course, massage you. There are eye bands that you put on, and they have colors coming in. There are all kinds of biofeedback and transcendental meditation and mind-body therapies, basically. So he spent his life doing this, and I was very fortunate because I said, so tell me what you've done with the research. And he said, actually, what we know is that when people come in, they self-rate. We take I think it was their blood pressure and their heart rate. But what we talked about was the self-report that people came to the stress lab with. And when they left 15 or 30 minutes later, they reported an over 3% or 3-point drop on a 10-point scale of their stress levels. So what I'm saying is, please go online. I didn't provide it for you here tonight, but his name is Olpin, O-L-P-I-N. Please go online and look up his stress management lab. One of his academic courses is offered totally free online. Totally free. And I sent this information to our state representatives last week after I met with them and said, here are the resources in the state of Utah that you can start bringing forward. As you're thinking about budget cuts, here's what's already there that's free. And he also has a book, as you'll see. He's created 2 for his courses and then 1 that's just for the general public, and discusses really straightforward what stress management is. And it is delightful. One of the nicest things, and sleep hygiene reminded me of this, is, and I'm cheating just a little bit here because in his book he says, don't do this before you go to sleep, but because your body will get, then when you want to use it in other ways. And I thought, I don't care, it works for me. So he says, what he did is he took transcendental meditation and he took out all the mysticism out of it. So basically you were just focusing your mind on one thought, one feeling, one sound. And he said it can be a candle, it can be a word, it can be like a color or something, but you just focus your mind on one thought or one element. And he said, and he says this in his book, and he told it to me personally, he said, other thoughts will come in, and you just kind of are aware of them, they come and go. And this is the mindfulness of it. And he said, but just still bring yourself back to that color or that word. So I anxiously went home and I thought, okay, I'm going to read through this book and see how I can reduce my stress. And I decided that was the one I was going to start with. And I focused on the word he suggested in the book, which is one. And so I say one about every 3 seconds. And I fell asleep. I don't know how many minutes it was, but I was gone. I thought, oh, this is great. This is really nice. So please look into his classes and what he's offering online, because they are so simple and they don't have a lot of elements that you have to put money out for.
What was his first name?
Michael at Weber State University, and he's in the health sciences department.
I'm wondering, if you wrap up your formal presentation, would you be available for about 15 minutes of questions?
I would be glad to. All right, so I'll wrap this up. So we've talked about this. It's the psychological imbalances can exist in fibromyalgia. I mean, seriously, who wouldn't have some depression and anxiety with all the symptoms going on with fibromyalgia? It's scary, it's depressing, it's, I remember telling my husband, if he said, well, what's your pain level? What did you report to the doctor? And I said, it's 187. He said, no, it has to be on a 10-point scale. I said, no, it's 187. And he said, what do you mean by that? And I said, every component of me hurts. I don't know how to describe it to you anymore, except that I cannot believe that a body really lives with this kind of pain. I would have thought that a body would give up and die instead of hurting and not functioning all the time. I remember that thought all the time. Really, a body can live through this. So the part of that is we need to be mentally healthy because we have a lot to deal with. So remember that, we won't cover that one about physicians. You're invited to Logan for the Walk to Cure FM. It's May 12th, and we are going to have a great day on it. I have some business cards. I forgot to print papers, and I apologize for that. I actually had a malfunction on my computer just before I came, and so I was precluded from doing that for you. But if you go to Walk to Cure FM, you're going to find us on the internet. And next year we're going to do it with Offer. We talked about it this year, but I never got my materials together soon enough. So some resources that I want to quickly refer you to are the Chronic Disease Self-Management Program that's offered through the Utah Health Department, and then Offer, and then the National Fibromyalgia and Chronic Pain Association. And thank you very much for coming and learning more about fibromyalgia, about how you can engage and help yourselves and help our community. It's an honor to be here with you, and I know what it took to get here. I know the pain, I know what you went through to get here, so thank you very much.
If a question is asked, repeating it in the microphone.
Absolutely. Yes.
I've been learning a lot about the caucus meetings that are coming up next week for Republicans and Democrats. When it comes to things like that, and we're thinking about delegates or representatives or legislatures, are there one or two questions that we should ask them? And if so, what should their responses be?
Absolutely. I do know the positions of the different legislators, both state and national, but I'm not going to talk about those tonight. But the questions that you should be asking are how they feel about Medicaid, how they feel about Medicare, because to balance the state budget in Utah, something has to give. And our population, being considered a chronic illness, along with the elderly, on Medicare Part B, is vulnerable, extremely vulnerable right now. So understanding their opinions on Medicare, particularly Part B, and Medicaid are crucial. On a national level, we need somebody who's going to go in and control this outrageous spending that's happening. We need to have somebody who understands healthcare issues, who has been involved either on the health committee or on one of the subcommittees. We need to have people who are willing to work across the board and join hands, because we're in a mess. Any other questions? Thank you.
I want to know if you have fibromyalgia and how you do that. You obviously do.
Her
How do
question.
you get it under control? I mean, you're in all these places doing all these things.
Her question was, if I have, or since I have fibromyalgia, how do I keep my pace? That's a key word, is my pace. Every person with fibromyalgia has come to it in a different way. Different combination, that's why I talked about the allostatic load. And so when you pay attention to your pain generators, then you'll know which area to focus on. If you have a problem with your low back, then you have a constant pain generator putting that information into your central nervous system. You need to take care of that low back. You need to stop that pain, because over time it changes the way that your brain responds to pain. The personal question of what did I do, I paid attention to my pain generators. I found methods that I could employ, and it took me a long time, diligent work every day with both physical methods and psychological methods to be able to find myself. And I didn't share this with you earlier, but I'll be real brief about this. When I turned 50, I stood up at my birthday table and I said, I can wear red hats, I can wear sparkly earrings, I can do whatever I want to, I don't have to answer to anybody. But I really I'm curious, I want to know more about life. I want to understand, more about the people that I live with, because I've been busy raising 5 children. And my husband has his own law firm, and so, that's where his attention was a lot of the years. So when I stood up and said that, little did I realize that I was actually foretelling my future. Because that was in July, and in December I had abdominal surgery. And when I woke up, and a lot of us can tell exactly when fibromyalgia hit us. Mine was at 11:35 a.m. on December 22nd in the Logan Regional Hospital in the recovery room in the surgery center. And when I woke up, and I was in ungodly pain. I mean, I didn't know what it had done to me. And the reason I'm sharing this with you is because we come to fibromyalgia in different ways. Mine was a sudden onset. I did have, as I look back, symptoms, but they were never bothersome. I mean, I lived through them. I still, led a very productive, happy life and was able to raise my children. But I know many, many people who are not, their symptoms are very serious. They can't raise their children. And one of the things that we promote for that is understanding our parents who have fibromyalgia. One of the events of our National Fibromyalgia Awareness Days is to recognize mothers and fathers who either have fibromyalgia or are raising children with fibromyalgia. And we encourage them to read with their kids. That's the best thing that they can do for their children when they have fibromyalgia. So I would be glad to speak with you personally later, but I feel just a little bit uncomfortable sharing exact protocols and stuff.
Are they teaching the doctors that there is a thing called fibromyalgia?
He asks if if they're teaching the doctors that there is such a thing as fibromyalgia. This is our biggest problem, sir. We know that the students, in fact, well, that's probably too close to home when I was preparing our walk last year and I approached somebody, everything was, they were going to be supportive, and it was an academic institution. And when I came back to have the paper signed, she said, we've changed our minds. And I said, what? Why would you not support our walk? Everything was good to go. And she said, well, I talked to my daughter, and she just graduated from medical school she's like 2 weeks ago, and she says there's no such thing as fibromyalgia. If you can give me 10 doctors in this community who support fibromyalgia that are well respected, then we will sign on. I was shocked, and so I went out, and it was easy to get doctors. I mean, I knew who they were, and so I brought them back to her, and she said, okay, we will do it. Well, it was interesting because I have to approve everybody who comes on and wants to be a part of our national organization online. And I saw her daughter's name. And I thought, oh, yay, maybe there's a little hope here. But I want to take that just a little further, because that's actually one of the recommendations in the Institute of Medicine, is that the pain management, understanding, and treatments be taught at the medical school level. We have a big push to do this and to bring to them what we already know. There's so much disparity between access to care and the kind of treatments that people really need. And the report is very clear that pain is so individual that that's why we're promoting self-management. And it's really important for patient, I apologize because that's an incorrect political term. We are people with fibromyalgia, we are not patients, and I apologize. So it's really important for people with fibromyalgia to take information to their clinicians, their physicians, those who are helping them. We have access to that kind of information. If you do searches, and I don't have the paper, I don't know if Offer still has it, but when I spoke before, I had a list of all of the places you could go online and do good research with Medline and PubMed and Advanced Google Scholar and stuff. But that's the biggest connection we have to make is with our emerging students, and then the licensing boards, that they require that the physicians that they license have a basic understanding of the pain management. So for instance, right now, my organization is creating continuing medical for a specific group for fibromyalgia. And we are very focused on helping them have tools to teach their patients, actually give to their patients, so that when their patients come back, then they will have an understanding of where to have that dialogue, so that the physician can use those 15 or 20 minutes really talking about the illness or what they're going to do with the plan, rather than just spending the time of validating the illness.
Is it going to be that we're going to have a test that the doctors can give that says have fibromyalgia?
He asks if there will be a test and it will be required to be given before doctors can say that there's fibromyalgia. No, not that I'm aware of in the foreseeable future. I mentioned this fibromyalgia impact questionnaire because it is the basis that all of the research for fibromyalgia has been built on, and almost all of that assessment is self-reporting from the patients, and that's why it's always had such rigorous scrutiny, is that there's no objective evidence. Well, that's not true anymore. We have fMRIs that show the different parts of our brain are engaged in the response to pain, and the most interesting one is the limbic system. And so we have, in the very center of our brains, we have a little area called, or it's a little gland called the amygdala. And the amygdala says, hey, you're safe. Oh, it's not safe. It's the meter there. Well, the amygdala is part of the limbic system, and the limbic system is very over-engaged in people with fibromyalgia. So when there's a pain generator and the central nervous system is being alarmed, the autonomic nervous system gets turned on. That's your fight or flight. So instead of being able to run away from the tiger, now you're in the cage with the tiger. And all of those neurochemicals are flooding the brain. And the cortisol, the substance P, the adrenaline, and the brain is trying to respond, but it can only respond so long. So I'm going way off of what you asked, but the fact is that we have the SPECT scans that show that different areas of the brain light up. I was talking to Dr. Wood in Houston a couple of years ago, and he said, I was a guinea pig for my own research, and he said that he wanted to know what it took for a person without fibromyalgia to feel the pain, for their brain to light up on the fMRI to the level that the people with fibromyalgia feel it. So he injected saline into his calf, into the muscle, until the level rose that he had the pain levels showing up on the fMRI. And he said it was horrible. He said, I would never do it again. But the point is that if you push on a person's thumb who has fibromyalgia 6 kilograms of pressure, and it basically it's when the thumbnail turns white, that's the pain, the amount of pain that it takes for the brain to respond as if you're in a lot of pain. And if you did that to my husband, he would barely notice it. And so we have these objective evidences now. We don't need we need to have biomarkers, because it's a faster way to show that there's fibromyalgia, because we don't have access every day to the fMRIs and the SPECT scans, so we have to go back to our other ways of measuring. And so trigger points are part of it, but they're actually not trigger points, they're tender points. And they are in a lot of different places other than the 18 that are specified on the fibromyalgia diagnostic criteria. The diagnostic criteria was created only for research. A group of researchers said, we need to all agree on basic criteria. And there's an international group, can't think of their name right now. Anyway, they set the standard or set the way that people do research so that we have apples to apples. And they decided that they would use 18 specific tender points on the body for research. And it started with one research project, and I can't remember her name, Linda, but she actually works here at the University of Utah. She was a graduate student at the time, and she went to work with the person who developed this diagnostic criteria for that research. And over time, it was adopted as the criteria, but it is not reflective because we know that, sometimes only your left side is in pain with the tender points and not the right side. But in order to meet the diagnostic criteria, it has to be bilateral, it has to be above and below the waist. So this is why I mentioned that the diagnostic criteria is in flux, because this has been an issue. It's never been disagreed that that was primarily designed for research. Yes?
Yeah, you mentioned that there was like approximately 70 different diagnoses that can lead to the fibromyalgia. Is there somewhere on the internet that you could look up the different diagnoses that are connected to fibromyalgia?
Do I have internet access here? I do on my phone. I'll set it up and I'll answer your question. She asks the question of whether or not we know quickly what the overlapping conditions are. And I know right where it is on my website, and so I'll try to pull that up real quick. Is there another question I can answer while I'm looking for that?
Yes, a lot of people are really ill, and like I did notice that health meeting that you mentioned, your Senator Hatch is involved on chronic pain. Do you have any suggestions for advocacy for, like I just been looking for things that come up on CFIDS and OperaSite.
I do. Thank you for asking that question. She asks she says she noticed that Senator Hatch was involved with the Health Committee, and if there's something that she can do, we can do as individuals to move this along, that she's been looking on the CFIDS website and such. Yes, very specifically. When I attended if you all have access to it, the Senate hearing, if you go to help.senate.gov and you go down about 4 hearings, there's one on pain relief in America, and it's about a 2-hour hearing. Well, here was the kicker. None of us saw this coming, but it was marvelous. So everybody had presented their research, the scientists, the IOM committee director, and Kristen Beasley, the person with chronic pain. And then if you watch this, you'll see. So Senator Harkin kind of leans back and he says, I'm sure you've all wondered why Dr. John Sarno's here. He hasn't testified yet or something to this effect. And we were wondering. I mean, it's my job to understand why people were chosen to be on, as witnesses. And so I could not connect that dot, honestly. And I had done enough research on him that I couldn't figure out which patient organization or which political ally he had. So Senator Harkin, he's the one, the reason I'm telling you this story is that interagency council that I showed you, he's in charge of that. The Health Committee's in charge of that. And he intends to take that forward strongly. But this is important for you to understand. He said, I invited him personally because, and then he relates about his chronic back pain and how over the years he had these problems and how he had actually had a cot laid out in the hall of the, I don't know which hallway, but in probably the Dirksen building, and how he was unable to get to some of his meetings and whatnot. So finally the 3rd time that he has this severe chronic pain in his back and he feels like he can't do anything, he goes to his physician and he's told, you have to have surgery. And he doesn't want to do that. And so he's talking to some of his friends, and one of his friends gives him a book by Dr. John Sarno. And I have not been able to find it locally. I just need to get on Amazon because I need to read it. But it was something about talking to your chronic back pain. And what Senator Harkin said in a nutshell is, folks, I believe that our pain is all psychosomatic. I'm telling you, there was this collective gasp in the room of like, oh my gosh, he's the head of this new interagency council, and he just told us that he brought this fellow who I know he has, important good work, and it's going to help a lot of people, but it really alarmed a lot of us because we know that there's pain that comes about, not psychological. I mean, what Kristen Beasley, I was so proud of Kristen. She thought about this for a while, and she had to bring things back on track. And if you watch this hearing, you'll see this happen. And she said, well, sir, what about the children who are born who don't have a sensation of pain? They didn't come into this world with any psychological trauma. How do we account for that? And Senator Harkin kind of looks, and thinks about it for a minute. And he acknowledges, there are probably different ways that people come to pain. But my point is that we need to be paying attention to the psychological aspect of chronic pain, because that's where this committee's headed. And that's one of the reasons I pointed it out tonight to our group, because where this committee goes with NIH and with the researchers and with the Senate support, there go the dollars for research. And so anyway.
And where specifically would you look?
For the hearing?
Not for the hearing per se, but like if there's like a call for action on the part of people who have the illness to advocate.
She's asking if there's a place to know when it's time to advocate, when to step forward and how to participate in advocacy. I know Offer does some things. I can't speak for you, Linda, but on our Facebook, I'll see if I have access to the internet yet, but on our Facebook, we issue calls quite often. And so here's our Facebook, and it was like 3 weeks ago, we had a call out for Rhode Island because we needed people to testify at the last minute opportunity that the bill was being heard the next day. And so we use our Facebook, and that's facebook.com/NFMCPA. What I wanted to show you was the overlapping illnesses. So this is our website, and you see here we have the overlapping conditions. And I've been criticized for putting this at the top and the bottom of the page, but quite frankly, I feel like people have to find it. So let's put it where they're going to look. So we have it divided between A to Z, and then the complete list. And then we, instead of discussing all of the specific components and concerns about each one of these, we actually refer you to a website or an organization that handles this. And then I just wanted to show you at the bottom real quick. Like I said, we doubled up here, and I put it at the bottom again.
Where can we go to understand the politics of the healthcare, the Affordable Care Act? All of these things are going on because it's very convoluted and confusing that other that to have a better understanding of it.
I'm not pulling it off the top of my head. There's a place that I go to all the time, and it gives timelines. And it's a government site. It's right there. This site is invaluable. What's changing and when? You see, for instance, CHIPS. I mean, does anybody know about CHIPS in this room? I had no idea. The government, maybe some people do. But anyway, they help you navigate the system, and they are in every state. Actually, they're available in every county. So this is an excellent website. Linda?
Please join me in applause for one of the most informative meetings we've had on fibromyalgia. In fact, it might be the very best. Thank you, Jan, for coming. She came all the way from Logan, and she's got to drive all the way back. And thank you all for coming. Is there any announcement that needs to be made from anyone very quickly between now and for our next month? Okay. Well, thanks a lot for coming.